Hi, everyone, and welcome back to the hashtag See Arthritis event here in the Arthritis Broadcast Network studio. I'm Cheryl Cohen, and I could not be happier than to be joined in the studio by Dr. Jean-Paul Makhzoum. Welcome to the studio, Dr. Makhzoum.
Thanks for having me.
Yeah, we're super excited to hear about the presentation that you just gave at the Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting. As you know, this hashtag See Arthritis event is in its 12th year. We're close to being in our teenage years, so we're excited about that. Before we dive into our conversation, Dr. Makhzoum, I'm going to tell our audience a little bit about you, if that's okay with you.
Perfect.
So, for our audience, Dr. Jean-Paul Makhzoum is a clinician scientist specializing in vasculitis at the Hôpital du Sacré-Coeur de Montréal and an associate professor at the University of Montreal. He is also the director of the Vasculitis Research Program and GCA Rapid Access Clinic at the Hôpital du Sacré-Coeur de Montréal. His just completed or no ongoing projects. His ongoing projects include a multi-center Canadian study to discover a new way to diagnose and monitor GCA by doing a simple, quick ultrasound of the eyes. Cannot wait to hear more about that, Dr. Makhzoum. Also, there's a study ongoing to find new treatments of GCA, such as abatacept, a drug that's currently used in more joint-based arthritis, such as rheumatoid arthritis and others, and also a study to better predict who might get relapses of GCA. And at the end of this talk, Dr. Makhzoum, we will give links to these studies because I understand you're still recruiting for them. Is that correct?
That's correct. Yes.
Excellent. So we're here to talk to Dr. Makhzoum about his participation in the rheumatology meeting that's ongoing here in Halifax. And the title of his talk, I love, Lighting Up the Arteries, How Imaging and Therapies Are Reshaping Large Vessel Vasculitis. Dr. Makhzoum, first, we're going to start where we should start, and that is please tell our audience kind of how you're situated in arthritis or rheumatology, and maybe give us a brief definition of what large vessel vasculitis, GCA, and those types of diseases that you're so expert in.
Well, first, thank you again for having me. So that's a really good question because so I'm a specialist in vasculitis. So these are inflammatory diseases that affect blood vessels. They can be small vessels, medium vessels, or big vessels. When we think about big or large vessels, it's the main artery of the heart, like the aorta, leaving from the heart and going elsewhere to the body, to the brain, the arms. Whereas small vessels are vessels that we can't see, that are very small in the kidneys, the skin, and so on. What's interesting is that all of these vasculitis in English, we say vasculitis for plural, um, they can also cause arthritis. They have other symptoms like fever, weight loss, and so the symptoms can be very vast and non-specific and can include arthritis as well. So this is the basis of my practice and my research program. So I focus on those vascular inflammatory disease, but that also can cause arthritis.
It's
And
unbelievable that arthritis and veins or vessels go together.
that's right. That's right.
Yeah.
And it could cause, the the large vessel vasculitides that we talked about is a giant cell arteritis, and this is the most common large vessel vasculitis in adults. And like I've mentioned, it affects the main large arteries like the aorta and its branches. And some of the branches that are affected are in the scalp, so cranial arteries. And because of that, patients can have headaches, scalp tenderness, difficulty chewing meals because of the arteries of the jaw are affected as well. And what we fear the most is visual symptoms and the risk of blindness, because roughly 1 out of 5 patients with this disease will become blind initially at the disease onset, and when that happens, it's usually irreversible.
Oh,
So this is why we really put all our energy into finding ways to diagnose it fast, quickly, efficiently to avoid that from happening.
right. And, when you say the disease, the symptom and the onset, that there, it's so vast, must make it very difficult to diagnose. And obviously it should be treated as a medical emergency. So I'm imagining a lot of people present in the emergency room.
That's right. They present in the ER or walk-in clinics, um, and patients are relatively unwell when they come because of all these symptoms and sometimes are hospitalized. But it is a medical emergency, and and so this is why we do research. It's rare in 2026. Most research projects are aimed to treat diseases, and this is one of those diseases where we're still figuring out the best way to diagnose it, and it's not frequent in our time period where there's still diseases that we can't really diagnose fast. So it's still a work in progress, and that's what we're doing. And the clinic we created, um, which is a rapid access clinic for giant cell arteritis. That's the whole purpose. It's a specialty clinic, but it's sort of an emergency clinic where we offer rapid diagnosis based on everything that we know.
Which is clearly needed to have the best outcomes, prevent blindness and other downstream complications of undiagnosed or untreated. Is this rapid access clinic, Dr. Makhzoum, is this sort of like a model that could be transported to other institutions, to other provinces?
Yes, absolutely. And many provinces and cities across Canada have already adopted a model similar to ours. So our clinic is ultrasound based, but there are some clinics that do other types of imaging to diagnose GCA, and so each city and center will adopt its own model. But the idea is to have a rapid referral system where we see patients rapidly. We combine this with a diagnostic test that's good in our center, and we try to make the most out of it to make an accurate diagnosis.
Yeah. When we think about the numbers of people, give us some sense. How many people in Canada are dealing with this?
So it's a rare disease. We don't know for sure how many patients in Canada have it, but we know that it's a disease that affects patients um, that are over the age of 50, and most of the patients are over the age of 70. So what we know for sure is that the population in Canada gets older, we will get more of giant cell arteritis. So just to give you a rough idea, um, we usually get about 200 patients a year with that disease in our center only. So out of 600 to 800 referrals. So it is we're seeing more of it, but it's still a rare disease.
Yeah. Okay, so now our audience has a sense about what this kind of rare disease or group of diseases is all about. Tell us a little bit about lighting up the arteries. What were some of the kind of takeaway messages en anglais from your presentation?
So I think there's three big messages. First message is that we are still not perfect on how to assess the disease, and we don't have a perfect tool yet to assess giant cell arteritis. We combine clinical symptoms, blood test, and imaging to make a whole out of this. It's all puzzle pieces that we put together. And these puzzle pieces, they don't always align well, so it makes it challenging. And sometimes, unfortunately, it's hard to conclude right away. We need a follow-up period to know if the disease is there or not.
Yeah.
So that's one of the first message. And I think for patients, I usually tell my patients, um, you'll have to be patient with me
Yeah.
because sometimes I don't have the clear answer, and that's not because we just don't know. It's just because there's nothing perfect, and we don't want to do a false diagnosis. The second message or takeaway message would be that it's exactly what we're lacking. We need accurate tools to make the diagnosis. And again, still more research is required for that. So we've seen research on ultrasound. There's research on PET scan, which is a nuclear medicine exam. There's research on MRI of temporal arteries and other arteries. So all of these are still required, and we're hopeful that either one exam will be excellent or a combination of exams will help us make an easier diagnosis. And I think the third message is regarding the treatment. And historically, giant cell arteritis was treated with prednisone or corticosteroids. And this was the only thing we used to have. And now we're evolving away from that. We're having more medications that are becoming options, allowing a personalized approach. We're taking the patient as a whole with the medical history, the history of the comorbidities, the other medications that the patient are taking, and we are able now to choose the right medication that could allow us to have less prednisone, which is associated with a lot of side effects.
And I guess that's one of the studies I mentioned earlier was this investigation into abatacept, which is a biologic. So that's great news that these investigations are going on. When we think about the second and third key message, the second one, have you, is there, so you talked about ultrasound, PET, and MRI. Most people out in the public know that it takes time to get an MRI and that you really have to be showing kind of really alarming symptoms to get a PET scan. You need it, usually if these are tests that have to be prescribed by a specialist. Is that correct? Yeah. So when you think about those three types of tests, what you're using in your rapid access clinic is the ultrasound. Am I correct?
That's correct.
And
Yeah.
and is that because it's fast, readily available, and can help get someone to an MRI or a PET, or is it definitive in and of itself?
So at our clinic, it's the definitive test for, I would say, 99% of the
Okay.
patient. We rarely need something else, which could be an MRI, a PET scan, or a biopsy of the temporal arteries itself. However, so that's the beauty of going to a rapid access clinic and having access to one. So most provinces will have a rapid access clinic, is that, those clinics are set up to have a rapid access negotiated to one of those exams,
Okay.
to either biopsy, an ultrasound, or an MRI, or a PET CT, and everything is set up there. So technically, those clinics um, shouldn't have any problems in accessing one of those specialized exams.
Okay. That's terrific. Thank you for that
Yeah.
clarification. So, kind of shifting to the meeting itself, you've had your presentation. I know it was a huge success, and everyone left knowing a lot more about lighting up the arteries and what imaging, how imaging and therapies are reshaping what you're doing in your clinics as we speak. The theme of this year's meeting is shifting tides, embracing change in rheumatology. When you think about that theme, I love it because we're in Halifax and we're right next to shifting tides. What does that look like in vasculitis? In the very specific area that you work in, what kind of things are you hoping to see? Maybe they're not here yet, but they're on the horizon in the next sort of 5 to 10 years.
It's a really good question, and it's a really an exciting time in vasculitis in general, because over the last 100 years, there was nothing happening in terms
Yeah.
of knowledge and research and so on. And in vasculitis, things have been shifting in the past 15 to 20 years. And right now, we have a good problem. The good problem is that we have too many research projects going on, and they're competing one against the other to include patients. But that's a good problem to have because it wasn't happening. So what we're seeing in vasculitis is more better personalized care. we are able to better predict, which patient will be doing good, which patient won't be doing good. Should we treat longer, less long, higher doses, lower doses? So all these personalized care that we really didn't have any idea before. So we're able to do more of this. It's still not perfect, but research is ongoing. And same for diagnostic tools, same for uh, the number of options we have to treat our patients. So it's really an exciting times, and I think that the more we have options for our patients, the better we will be at learning what uh, option is better for each specific patient. Because before that, it was, one size fit all measure. We had the disease, we gave that treatment, that was the only option, and we're shifting away from that, and I'm really happy about this.
Yeah, that's amazing. And I think you mentioned one of the first key message of those at your presentation was research around new diagnostic tools. So, in order for a person to get well, they have to go through this process, which is symptom arrival. Something's going wrong and you don't know, and you go to seek care for it. You get to someone who has the right diagnostic tools to quickly diagnose, right?
That's
Then you
right.
get to the right therapy, right person, right drug, right time, right amount, right duration. And then the person is living their life and having good health outcomes and hopefully not seeing you in your clinic as often. So that's the perfect world pre-cure. I mean, I know everyone is still working on cures in all types of arthritis, including vasculitis. Well, that's very exciting, Dr. Makhzoum. We cannot thank you enough for sitting with us. In your parting words, there are hopefully people with vasculitis watching. Um, you have this incredible body of knowledge, clinical research, medical. If you were to sort of give one or two pieces of encouragement to someone with vasculitis, what would that be? What could you say to them that would help them, not just in your relationship with their physician, whether it's you or someone else here in Canada or anywhere else in the world, but also how can the person with vasculitis turn around and be a better advocate for themselves in their
It's a re
journey?
it's a really good question. I think one of the most important thing to remember is, these are devastating diseases, and
Yeah.
and once you get the diagnosis, a lot of patients will read on them and will be scared about what it can cause, and some of them could be life-threatening or organ-threatening. So I think the key message and the most important message is that vasculitis is treatable.
Yeah.
It is treatable. It will change a patient's life in terms of having follow-ups, blood tests, and it takes a commitment and there's treatments, but it is treatable. And I think one of the most important things is to ask questions to your doctor, all the questions. Don't be shy to ask things that seem simple or silly for you, but there's no silly
Ask.
questions. Just ask all the questions. Don't leave things in the gray zone because it's not going to be helpful in the in the long run. And obviously to follow all the advice of the treating physician, but also, on the patient's end, it's really important to try to live a normal life, to remain physically active as much as possible, to eat well, and all the basic things that everyone should do, avoiding the excess weight. If there's high blood pressure, to control it, high blood sugar, to control it well, with all the other health issues, because it can influence the vasculitis and the treatment of the vasculitis. So if we take care of ourselves and ask questions, hopefully all the rest will be it will be a smooth ride. But it is treatable, and not to be discouraged.
Yeah, I think that's such a positive message to end our conversation with Dr. Makhzoum. The word that kept popping up in my head as you were speaking was act. If I could do one thing, if I have vasculitis, it's to gain knowledge, learn, work with qualified people to overcome the fear that you mentioned, which is completely understandable. It's important to validate that fear so that you can learn how to kind of deal with it, overcome it, if you will. and then act. Make knowledgeable, informed decisions. We're such an important part of the care team with you, the expert physician. Without us, that decision-making tree kind of falls apart. So thank you so much, Dr. Makhzoum. It's been so insightful speaking with you. We're so lucky to have experts like you in this country doing work on this rare disease and for people who are dealing with it. We, at the end of this, will provide links to your research studies, also to information that can be found on our website and other patient organizational websites. And we invite feedback. So we'll have that email address for you as well. So thank you again, Dr. Makhzoum. We hope you enjoy the rest of the meeting and safe travel home when it's done.
Thank you so much. Thanks for having me again.
Thanks. And thank you to our audience for tuning in. There'll be another episode of #CartArthritis coming soon. Bye for now.